During the holy month of Ramadan, 300 specially invited guests assembled at the King Faisal Hall in Riyadh for a demonstration of telemedicine. The principal guests were His Royal Highness Prince Mohammed bin Nayef bin Abdul Aziz and the Deputy Minister of Health, Dr. Abdul Rahman Al Suela. The demonstration had been graciously sponsored by the Minister of Health, His Excellency Mr. Faisal Al Hujailan, who had allowed it to be staged in the magnificent surroundings of the King Faisal Hall Conference Center.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. والصلاة والسلام على خاتم المرسلين سيدنا محمد صلى الله عليه وسلم. صاحب السمو الملكي الأمير محمد بن نايف بن عبد العزيز، سعادة الدكتور عبد الرحمن السويلم وكيل وزارة الصحة للشؤون التنفيذية، أصحاب المعالي والسعادة، حضرات الزملاء والمدعوين، خير ما نبدأ به ندوتنا هذه القرآن الكريم. المقرئ الأخ محمد الحذيفي يتلو علينا آية من الذكر الحكيم.
السلام عليكم ورحمة الله. أعوذ بالله من الشيطان الرجيم. يا أيها الذين آمنوا اتقوا الله ولتنظر نفس ما قدمت لغد واتقوا الله إن الله خبير بما تعملون. ولا تكونوا كالذين نسوا الله فأنساهم أنفسهم أولئك هم الفاسقون. لا يستوي أصحاب النار وأصحاب الجنة. أصحاب الجنة هم الفائزون. لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله. وتلك الأمثال نضربها للناس لعلهم يتفكرون. هو الله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم. هو الله الذي لا إله إلا هو لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر. سبحان الله عما يشركون. هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم. صدق الله العظيم.
صدق الله العظيم. تحت رعاية صاحب المعالي الأستاذ فيصل الحجيلان وزير الصحة، ممثلا بسعادة الدكتور عبد الرحمن السويلم، نبدأ ندوتنا هذه عن الطب الاتصالي، والتي شارك في إعدادها وتحضيرها مستشفى ماساتشوستس العام، أكبر وأقدم المستشفيات التعليمية لجامعة هارفارد الطبية والمؤسسات المتعاونة معها. ويسعدني في هذه المناسبة أن أرحب بضيوفنا الكرام لتشريفهم ندوتنا هذه كما أرحب بوفد مستشفى ماساتشوستس برئاسة الدكتور روبرت بيوكانان. لقد تحقق في السنوات القليلة الماضية تطور هائل وفعال في مجال الاتصالات ونقل المعلومات، استفادت منه قطاعات عديدة، نذكر منها على سبيل المثال لا الحصر المؤسسات العسكرية، البنوك والقطاع المصرفي، شركات الهندسة الكبرى، الصحافة والإعلام والتلفزة. ولم يكن للقطاع الطبي حتى يومنا هذا نصيب يذكر في هذا التطور، وذلك لأسباب عديدة، أهمها يرجع إلى الكم الضخم من المعلومات التي تحتويها المواد التشخيصية من دراسات في الأشعة أو الأنسجة، مما يشكل عائقاً فنياً لإرساله بواسطة أجهزة الاتصالات العادية، لما يستغرقه ذلك من الوقت. وما يعنينا اليوم هو أن نؤكد أنه أصبح متوفراً الآن، وبفضل العمل الدؤوب لمجموعة من العلماء في جامعة هارفارد الطبية ومستشفى ماساتشوستس العام، وسيلة عملية وبسيطة لتبادل كافة المعلومات الطبية بواسطة خطوط الهاتف العادية، مما يشكل منهجاً جديداً في مجال الطب. إن حكومة المملكة العربية السعودية الرشيدة بقيادة خادم الحرمين الشريفين قد وضعت نصب أعينها منذ البداية تطوير الخدمات الطبية في أنحاء المملكة، مما أدى إلى نشوء مؤسسات طبية تماثل في مستواها صروح العلم في أمريكا وأوروبا. وهنا يجب أن نسأل أنفسنا ضمن هذه المعطيات عن حاجة المملكة إلى هذه التقنية الحديثة. سأترك الجواب على هذا السؤال إلى نهاية ندوتنا هذه، وذلك بعد مشاهدتكم لهذه التجربة الفريدة للطب الاتصالي. أترك الكلمة الآن لسعادة الدكتور عبد الرحمن السويلم، وكيل وزارة الصحة للشؤون التنفيذية.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله صاحب السمو الملكي الأمير محمد بن نايف بن عبد العزيز، ضيوف الندوة، أيها الزملاء، السلام عليكم ورحمة الله وبركاته. يسعدني نيابة عن معالي وزير الصحة الأستاذ فيصل الحجيلان أن أرحب بكم في هذا الملتقى العلمي، وأن أبارك هذا الجمع من الأطباء والمعنيين بالخدمات الطبية والصحية، وأتطلع إلى أن تؤتي هذه الندوة المتخصصة ثمارها في شرح إحدى وسائل تقنية الاتصال المستخدمة في الأغراض الطبية، وما سيقدمه هذا النوع من التقنية من إسهام فاعل في تطوير الخدمات الصحية المقدمة للمرضى، إضافة إلى إسهامها في خفض تكاليف العلاج من خلال التعاون مع المراكز العلمية المتخصصة وتقديم الاستشارات الطبية سواء في مجال التشخيص أو العلاج. فلم يعد الطبيب اليوم كما كان في السابق يعتمد على مهاراته وخبراته في التشخيص والعلاج فحسب، بل أصبح أمامه ومعه فريق متخصص يشترك في تشخيص مريضه ورسم خطة علاجه، وذلك من خلال استخدامه لتقنية الاتصالات الحديثة بعيداً عن موقع المريض ومكان معالجته، وبهذه الوسيلة يمكن ربط أقل المراكز حظاً بالمختصين بأكبر المراكز العالمية، مما يوفر على المريض عناء السفر ومشقة الانتقال لمثل هذه المواقع. كما سيتيح لنا الاستفادة من الكفاءات المتخصصة والمتميزة في دول العالم المتقدم أياً كانت مواقعه، دون أن يكونوا مضطرين إلى السفر والانتقال، فاستقطاب مثل هذه الكفاءات قد يصعب لندرتهم وارتفاع أجورهم. صاحب السمو، أيها الحفل الكريم، لقد تميزت الخدمات الصحية بالمملكة العربية السعودية بتطورها السريع وأخذها بأسباب العلم والتقنية واستقطاب الكفاءات المتميزة، وهكذا نمت الرعاية الصحية في بلادنا كماً ونوعاً بفضل الله، ثم بفضل ما توليه حكومتنا الرشيدة للرعاية الصحية من دعم وما تحظى به من متابعة واهتمام من خادم الحرمين الشريفين وسمو ولي عهده الأمين. فأصبح لدينا مراكز علمية متخصصة في زراعة الأعضاء وعلاج أمراض القلب والسرطان والتوسع في جراحة المناظير والاهتمام ببرامج الجودة النوعية. كما أولت وزارة الصحة في برامجها الوقائية برامج مكافحة أمراض السكر والقلب والسرطان بالغ الاهتمام. إلى جانب ذلك فقد عمت الخدمة الصحية أرجاء المملكة، فقد أصبح لدينا الآن أكثر من 278 مستشفى، منها 174 مستشفى تابعا لوزارة الصحة، و32 منها تابعا لجهات حكومية أخرى، و72 مستشفى للقطاع الخاص. كما بلغ عدد المراكز الصحية والمنتشرة في أرجاء المملكة 2220، منها 1710 تابع لوزارة الصحة، و510 مستوصفا للقطاع الخاص. وأصبح عدد الأسرة في وزارة الصحة وحدها 27,000 سرير. كما بلغ عدد الأطباء العاملين في هذه المواقع في وزارة الصحة 26,151 طبيباً و28,320 فنياً، علاوة على 53,867 ممرضاً وممرضة في هذه القطاعات الصحية. إن هذه النهضة الصحية التي تعيشها مملكتنا تميزت بأخذها بأسباب التقدم ووسائله وانفتاحها على كل ما هو جديد، بالإضافة إلى التعاون مع المراكز العالمية المتميزة. وهذه التقنية التي نحن بصددها في هذه الندوة واحدة من الوسائل التي ستساهم في ربط الأطباء والخدمات الصحية في المملكة مع جامعات عريقة كجامعة هارفارد ومستشفياتها الجامعية، كما أنها فرصة لانتقال المعارف ونتائج البحوث الطبية والمساهمة في مجالات التعليم والتدريب، كما ستساعد على الوثبة التنموية الشاملة في بلادنا بإذن الله. مرة أخرى أرحب بكم متمنيا للقائكم كل توفيق وسداد. السلام عليكم ورحمة الله وبركاته.
قبل أن نتابع هذه الندوة، أود أن أتوجه بالشكر لسعادة الأستاذ عبد الرحمن السويلم للكلمة التي سمعناها حول اهتمام وزارة الصحة بهذه الخدمة المتميزة. أود الآن أن أقدم الأستاذ يوسف الزين، الرئيس التنفيذي لمجموعة الطب الاتصالي المتعاونة مع مستشفى ماساتشوستس العام.
Your Royal Highness, Your Excellencies, distinguished members of the medical profession, gentlemen. it's with great pleasure that I stand here on behalf of the group that has developed the technology and application of telemedicine over the last 3 years. This is the group led by the Massachusetts General Hospital, Harvard's oldest and largest teaching hospital. It is also with great pleasure to hear His Excellency Dr. Swalem express his belief as to the uses and benefits of telemedicine, ensuring that hopefully our efforts that have been expanded in the last few years will bear fruits. If we came to Riyadh 4 years ago to demonstrate telemedicine, the equipment in front of you would have been 10 times bigger, with half the power, at a cost 10 to 15 times the equipment we see here tonight. To reach the point where we can demonstrate telemedicine to this distinguished audience in this beautiful hall using normal dial-up telephone lines supplied by the Saudi PTT, some substantial technological breakthroughs had to be developed. These developments could not have happened without the absolute commitment of one of the world's largest and most prestigious medical institutions, whose Director General, Professor Robert Buchanan, will tell us more about that commitment later tonight. Professor Buchanan, who is Professor of Medicine at Harvard Medical School and Director General of Massachusetts General Hospital, comes there from being the Dean of the School of Medicine at Cornell University. However, the commitment of the Massachusetts General Hospital is not one aimed at the development of equipment, but rather it had the objective of sharing medical excellence with the rest of the world. Professor James Thrall, Chairman of the MGH Radiology Department and Professor of Radiology at Harvard, will tell us more about his concept of telemedicine. Professor Thrall has led the way to develop the service of telemedicine as we know it and as we will demonstrate it tonight. A concept based on a deep-rooted commitment to excellence and change. A change which is at the roots of innovation and invention that makes MGH and Harvard different. I would like to point also that the team assembled to develop telemedicine included people of outstanding qualifications, like those of Drs. Goldberg, Cropper, like Schaefer, and Flott, all of whom combine unique specialization in medicine and electronics that made this possible today. I also cannot forget the contribution of an outstanding clinician, a member of our group, Dr. Ricky Richardson, who, as a consultant pediatrician for the Hospital for Sick Children, Great Ormond Street in England, has made it his life career to help instituting medical practices the world around, and has over the last 2 years dedicated himself to finding the most efficient way of how to make telemedicine available to various healthcare systems. Saudi Arabia has been his focus, and he will share with us tonight the plans developed to bring telemedicine to the kingdom. Finally, on behalf of the telemedicine group presented here tonight, I wish to sincerely extend our thanks to our hosts tonight, His Excellency Mr. Faisal Al-Hujailan, who has so generously extended to us a very rare welcome, of which we are proud, by agreeing to be the sponsor of this event. Special thanks also go to His Excellency Dr. Swalem for his kind speech. Let me at this point introduce Dr. James Thrall for his presentation and the demonstration. Thank you very much.
Your Royal Highness, Your Excellencies, distinguished members of the medical community, gentlemen, it is an honor to come before you this evening to discuss the concept of telemedicine and present a live demonstration of telemedicine for you. Many of you, if we could have the next slide, many of you may wonder why it has taken so long for telemedicine to become a practical reality, since computers and modern telecommunication systems are in routine use in many industries, including banking, finance, and the world of entertainment. Simply stated, medical information has higher requirements for resolution and fidelity, especially X-ray images, than any other kind of data. For example, one chest X-ray requires more computer memory than the entire contents of the London telephone directory. It has only been in the last several years that the computer and telecommunications technology has been developed to make telemedicine widely available. We are now poised for a dramatic new era in the way medicine is practiced and in the way healthcare is made accessible to patients around the world. To put telemedicine in historical perspective, 25 years ago at the Massachusetts General Hospital, there was an attempt by Dr. Kenneth Bird to implement a telemedicine service. I think he proved the concept to us, but at that time, the kind of video link and the kind of data transmission was simply not adequate to the high fidelity required for the best medical care. Image quality, and that of course is the basis of radiologic and pathologic diagnosis. Image quality was inferior to that achievable with modern digital techniques. Next slide. We define telemedicine as the delivery of care to patients anywhere in the world by combining communications technology with medical expertise. The goal of telemedicine is to improve the quality of care to patients and decrease the cost of that care while keeping more people in their own healthcare system. Next slide. Telemedical services that are now available and in use in the United States include teleradiology. You will see a demonstration of that this evening. Telepathology, you will also see a demonstration of telepathology. Another important aspect of telemedicine is patient management consultations. These can either be done directly through a video teleconferencing system or through the exchange of data about a patient. Running through all of our considerations of telemedicine is the consideration of quality assurance. This is extremely important as we expand the scope of healthcare on a global basis. Equally important is the opportunity to use these telemedicine systems for continuing medical education and collaborative research. Next slide. Emerging telemedicine services include some of the things listed on this slide. I won't talk about all of them in detail, but let me just highlight a couple of these applications. It is now possible to use a special video camera interfaced to an endoscopy system to capture images and share them on a remote basis. It is also possible to do a remote physical examination, especially if a nurse or other paramedical person is available to help. We can integrate the stethoscopic examination, ophthalmologic and otoscopic exam into the system. Other more exotic treatments are telepresence surgery. Robotic systems and remote techniques are being developed in the United States to allow a surgeon at one institution to participate in an operation actually being performed in a different institution. Next slide. The teleradiology applications that have become important include primary interpretation. This is suitable in a situation where a radiologist is not present, but very often there is a radiologist at an institution who would like to share a case with a colleague and ask for a second opinion, or perhaps a patient would like to have a second opinion before undergoing a major operation or therapy. Quality assurance and medical education are also services of teleradiology. Next slide. Telepathology will be the subject of the next presentation. It includes both primary or secondary consultations and uses a high-resolution digital imaging system and color display. This can be integrated right into the teleradiology system. Next slide. Now, a typical acquisition site for telemedicine is illustrated here. And while we're looking at this slide, I would like to ask Amer Taba to come to the front of the room and begin our live demonstration. Amer, if you will take the film and begin the scanning process, we will walk through the actual steps that are used in sending an X-ray study from the Kingdom of Saudi Arabia to Boston, Massachusetts in the United States. Mr. Taba has put the film in the special digitizer station and has clicked on the computer screen to initiate the acquisition of the data. If you look at the slide up on the screen, you'll see the film digitizer station is illustrated in the lower left-hand part of the slide. When the study is digitized, and you can see it now coming up on the screen, this is the actual digitization of the radiographic study. The data is carried by a local area network onto the image server. And from the image server, it is sent over a standard telephone line to the United States. And we'll be joining a team of telemedicine specialists in the United States a little later for their interpretation of this radiographic examination. Now, it's also possible to directly interface a CT scanner or an MRI scanner onto the local area network and capture the original digital data directly from the scanner. You will also see the results of the interface of a telepathology system with the network and the transmission trans-Atlantically and transcontinentally. For that, we use a special microscope with a camera, digital camera interfaced to it. So we've completed the digitization of this film. Mr. Taba has saved it. It has now disappeared into the innards of the computer system and is on its way to the United States. So we will join that image a little later in the program, if I could have the next slide. Now, what's going to happen when that image arrives in the United States over the wide area network, it will come in again through network access equipment and be taken into the local area network for display or printing on a laser printer or storage for later review. So you see the diagnostic workstation, which Mr. Taba is now illustrating. The image that has come up on this workstation will be displayed in about 5 minutes on an absolutely identical workstation in our department in Boston. Next slide. And we'll ask Mr. Taba to magnify one of the images. This is the way we actually practice radiology in a modern radiology department, using the computer and digital imaging. Now, the brains of the telemedicine system is the information system. The telemedicine information system controls the routing of the study. It knows exactly which phone line to send it over so it gets to the right place. It knows the correct doctor to interpret the image. And then when the report is ready to be sent back, the information system controls that transmission as well. Next slide. Now, the basic technologies and the basic services for telemedicine are teleradiology and telepathology. But it is also possible now, using standard telephone lines, to implement video conferencing. And video conferencing may be valuable and may be desirable in certain healthcare settings. For example, the video conferencing that we will be demonstrating with our team from Boston allows patients and doctors to establish a direct face-to-face communication over a long distance. It also allows medical colleagues who want to come together to discuss a particularly difficult case, or medical colleagues that want to come together and have a continuing medical education session to do so in a much more personal way than just a telephone call or a pre-prepared videotape. So the applications for video conferencing are as you see them, and in some very specialized applications, we can actually do remote diagnosis where a physician in one institution can view a patient and go through a physical examination and a diagnostic process for a patient in an entirely different institution at a remote location. Next slide. So the video conferencing is really very simple. In this room, we have a number of television cameras. They are sending a signal to Boston, and at the same time, the television camera in Boston will be sending a signal back to us. Next slide. As I mentioned, quality assurance is always uppermost in our minds, and it pertains both to the quality of the care that is actually delivered to a patient and the quality control of the technology. So every telemedicine application that we develop has built into it a very rigorous medical care and technical quality control program. Next slide. We mentioned that it has taken a long time for telemedicine to become a practical reality. This is a very busy slide, and I'm afraid I need to show you one or two slides with lots of numbers to illustrate this point. If you look at the left-hand column, you'll see a list of the different kinds of radiologic examinations that we do in our department. The digitized radiograph, of course, is the standard chest x-ray or skeletal x-ray and so on. Computed tomography, MRI, ultrasound, and fluoroscopy, nuclear medicine. Now, if I can just call your attention to the top row of numbers, you can see that we digitize the radiographs into a matrix that is 2,000 by 2,000 lines. For comparison purposes, high-definition television is only 1,000 by 1,000 lines, and standard television that we use today is only 500 by 500 lines. So by the time we get an average study that has 4 images in it, we have 34 megabytes of data. And just to remind you, each one of those images has more information in it than the London telephone directory. This is a huge amount of data. Next slide. Now, if we were to use a standard telephone line, and I call your attention to the digitized radiograph and the first column of numbers where it says 9.6 kilobits per second. If we were to use standard phone line and no other technical maneuver, it would take us 696 minutes to transmit one case. That's 12 hours or half a day. So this is clearly not feasible for any kind of practical telemedicine service. So what we have done, next slide, is to develop a highly specialized kind of data compression. You can think of data compression very intuitively by imagining all of the paperwork in the filing cabinets in your office. One way to compress the data is to put it on an optical computer disk. But we've taken that one step farther, next slide, and developed a proprietary technique so that once the data is actually in the computer, we can further compress it by a factor of 10 to 1 and up to a factor of 60 to 1. And because the image transmission time is affected directly by the amount of compression, this decreases both the transmission time and the cost of transmission by a factor of 10 to 60-fold. This dramatic reduction in the transmission burden, the transmission time and cost, enables us to use existing telecommunications infrastructure. We do not require any new telecommunications, and allows a very high volume of data transfer to any location that has a telephone system going to it today. Next slide. Just to show you that this works, here is an original radiograph. This is not compressed at all. The physicians in the audience will recognize a right hilar mass, a nodule in the right lower lobe, deviation of the trachea by a superior mediastinal mass, probably arising from the thyroid. The next image that you will see has been compressed by a factor of 60 to 1. So please just get a mental image of this X-ray, and we will now go on to the next slide. The next slide, please. And you can hardly see any change. We have validated this technology in our department by blinding observers and having them look at original radiographs and radiographs that have undergone the compression and decompression technique. Next slide. Now we can also do this with computed tomography. This is an unfortunate patient with pneumocystis carinii pneumonia, and again the doctors in the audience will recognize the pneumonia and the little area of cavitation in the lung. The original image, 10 to 1 compression. Next slide. We go on to 15 to 1 and even 20 to 1 compression, and the quality of the image remains outstanding. Now the practical result of this, next slide. And I call your attention again to the two columns, one headed on the left that says compression ratio, and then back to our 9.6 kilobits per second. If we do no compression at all and send the image with a 1-to-1 ratio, it's going to take 696 minutes. If we compress that image by 30 to 1, it reduces the time to 23 minutes. And then, as we're doing tonight, we're actually using 4 telephone lines in parallel. So we can further reduce the time of transmission by a factor of 4. This gets the total transmission time to about 5 minutes, which is a very feasible and reasonable time for the vast majority of medical applications. So this is an important enabling technology that we are using and will be the basis for the images that are transmitted to the United States in this demonstration. Next slide. So in conclusion of this part of the program, and then we'll go on to the discussion with the people in Boston, advances in computing power and telecommunications will continue to increase the cost effectiveness and expand the scope of telemedical services. Telemedicine is an emerging concept that we believe will revolutionize the delivery of care to the benefit of healthcare systems, to the benefit of doctors and other healthcare professionals, and most importantly, to the benefit of our patients. We envision the rapid growth of a global electronically linked medical community, and we invite you to share with us in this wonderful opportunity. Thank you. Now I would like to ask Dr. Gropper to reverse the telecommunications image so that we go to a large image in Boston and a small image here in Saudi Arabia. And if I could invite the team in Boston, Dr. Mark Goldberg is the Director of Teleradiology at Mass General. He's standing by with a team of telemedicine specialists, radiologists, and pathologists. Good afternoon, Dr. Goldberg.
Good evening, Dr. Thrall, and thank you very much for inviting us to join you this evening in Riyadh.
Well, thank you. We have sent you a case Earlier in the discussion, did the images arrive?
The images arrived as you were about halfway through your discussion, and they're displayed on the high-resolution workstation, which you can see here behind me.
Dr. Goldberg, would you introduce the members of your team, and then when you are ready to discuss the image, we are ready to listen to your discussion.
Thank you very much. If we can pan the camera over toward my right, the first physician I'd like to introduce is Dr. Mini Bala. Dr. Bala is an expert in thoracic radiology. Seated next to Dr. Bala is Dr. Sanjay Saini. Dr. Saini is an expert in abdominal imaging as well as being the director of computed tomography at Mass General Hospital. Seated on my other side is Dr. Gil Gonzalez. Dr. Gonzalez is the director of MR imaging at Mass General Hospital. Seated immediately adjacent to him is Dr. Daniel Rosenthal, who is the associate radiologist in chief at Massachusetts General Hospital, as well as being the director of the Division of Musculoskeletal Imaging. Seated to Dr. Rosenthal's right is Dr. Stephen Dawson, who is an expert in abdominal imaging, as well as the head of the interventional radiology group for abdominal processes.
Very good. Are you ready to discuss the case?
We are, and I'm going to invite Dr. Saini, who is seated with me here adjacent to the workstation, to discuss the images from an abdominal CT which have been transmitted to us. I would ask you if you could provide us with any history about the case before we begin our discussion.
Okay, let me ask Dr. Sharif to return to the podium to provide clinical information on this case.
Good afternoon, Mark. This is a case which we have sent you earlier, the CT, the MR of the brain with bilateral orbital masses. He had done an abdominal CT, which you see here. He's a 70-year-old man with generalized weakness.
Okay, we will begin with a discussion of the case which was transmitted live during Dr. Thrall's discussion, which is the abdominal CT. Dr. Saini, your comments.
Good evening, Dr. Sharif and colleagues.
Good evening.
We have 4 selected images from a CT scan that was done on the 10th of January. The images are from the upper abdomen. 3 of the images have been performed following the intravenous administration of contrast. One of the images was performed prior to intravenous administration of contrast. These images at the level of the kidneys demonstrate a diffuse abnormality in the retroperitoneum. If there is lymph adenopathy associated with this process in the retroperitoneum, it may be obscured this potentially inflammatory process. Given the history, this gentleman is elderly and has a generalized complaint as well as an abnormality in his orbital area. My inclination is to consider some sort of a neoplastic process. And one neoplastic process that comes to mind would be lymphoma, which is more infiltrative in its behavior rather than more mass-like. The possibilities to consider would be an inflammatory mass such as pancreatitis, although it would be unusual. This manifestation would be unusual for pancreatitis and certainly would not explain the orbital pathology. It should also be considered that the orbital pathology may be an incidental finding, in which case one might think of a process that is producing hemorrhage in the retroperitoneum involving both the posterior pararenal spaces as well as the perirenal spaces. If the patient's coagulopathy were available, that would be an important additional clinical information. patient. But at this point, my sense is that this is a neoplastic infiltrative process, and the most likely diagnosis would be lymphoma.
So, Dr. Sharif, to summarize, if we are to combine the findings in the orbits as well as the abdominal findings, the one coherent diagnosis that seems plausible would be lymphoma. Unless you have any other history, for example, is this patient have a coagulopathy that may have predisposed them to bleeding, or is the patient on an anticoagulant medication?
I honestly can't help you here, but I have left this patient a few days ago with an aim of taking a biopsy either from the abdomen or from the orbital lesion. I am not aware if they have. I'll be asking my colleagues and come back to you on this later. But at this stage, Mark, I would be grateful if you can send us by communication here the report of Dr. Sanjay, as this will be kept in the patient's file. Now, at this stage, I would like to ask you if you have received an earlier study which we have sent to you for an MR of the brain of a 12-year-old boy.
Yes, Dr. Sharif, we have received the other image. I'm going to invite Dr. Gonzalez, who is an expert in neuroradiology, now to join us in the discussion of that case, which we received earlier, as I bring it up for display on the workstation.
Dr. Gonzalez, do you need some history?
Yes, I would greatly appreciate some history.
This is a 12-year-old, born premature, has been noticed by his family to have an enlarging head. He has weakness in both lower limbs, no accurate intellectual deficit is noticed, and the question for the abnormality that you see is what to do next. As you will realize from the abnormalities that we're just not aware as what is the optimal way to deal with this case.
Thank you. What we have, Steve, is a sagittal T1 weighted images through the head of this 10-year-old boy. The study was performed without intravenous contrast.
That's correct.
There is severe enlargement of the lateral, third, and fourth ventricles, consistent with hydrocephalus. There is obvious flow void at the level of the aqueduct of Sylvius, as well as flow void at the level of the foramen of Magenti, consistent with hyperdynamic flow through these foramina. This constellation of findings is consistent with a communicating hydrocephalus. The fact that this child had a problem since birth suggests that there is a congenital etiology to this abnormality. I would also like to note that the inferior aspect of the cerebellum is displaced superiorly, which is an unusual finding in communicating hydrocephalus. There are two general possibilities that I would consider in this case. One would be an infection that occurred in utero that resulted in obstructive process at the level of the granulation body or at the level of the cistern, causing a communicating hydrocephalus. The second congenital possibility is suggested by this unusual superior displacement of the inferior cerebellum, and that is an unusual location of an arachnoid cyst at the level of the foramen of Magenti, causing mass effect, causing obstructive hydrocephalus. In terms of follow-up study or further evaluation, I would recommend therapeutic intervention
follow-up imaging. If this case, if you perform a ventriculostomy tube, placing a catheter within one of the ventricles, you would reduce the pressure, and we would image immediately afterwards or at some point afterwards, and we would evaluate the posterior fossa. If the posterior fossa revealed that there is no reduction in the mass effect upon the cerebellum, then this most likely represents an arachnoid cyst. However, if there's reduction of the mass effect, then this most likely represents a process at the level of the cisterns and arachnoid granulation.
Thank you very much, Dr. Gonzalez. The neurosurgeons are here and they have heard your comments, and we will carry this case further from this end. Thank you very much indeed.
Welcome.
And Dr. Goldberg and team members, thank you very much for joining us. This is, I guess, what we're now calling telepresence. You have been through the video conferencing for at least a little while with us here in the Kingdom of Saudi Arabia. Thank you again. And we'll now, I'll turn the podium over to Stephen Blackschaffer, who is the Vice Chairman of the Department of Pathology at the Massachusetts General Hospital, and to Dr. Tom Float, who is the Director of Telepathology for the discussion and demonstration of telepathology. Dr. Blackschaffer, thank you.
Thank you, Dr. Thrall. Good evening, Your Royal Highness, Your Excellencies, members of the medical profession, and gentlemen. Dr. Thrall's excellent introduction to telemedicine in general leaves me free to discuss those ways in which telepathology is similar to and those ways in which it is different from teleradiology. Next slide. Let me start by introducing our department, the Department of Pathology at the Massachusetts General Hospital. It is composed of 60 staff pathologists, a large number even for a hospital of 1,000 beds by many standards, but as you'll see, there's a good reason for the large number of pathologists. In addition to the 60 staff pathologists, we have at any given time approximately 50 pathologists in training. Of these, 20 are fellows, pathologists who have already qualified as general pathologists and are learning a subspecialty. The remaining 30 are fully qualified physicians who are learning the specialty of pathology. At our institution, we process 42,000 surgical pathology specimens and 40,000 cytology specimens annually, as well as 5,000 referral consultations. Pathologists and in general physicians in the audience may know the members of our department best from our weekly CPCs in the New England Journal of Medicine, possibly the premier general medical publication in the world today. On the video monitor, you can see another member of our department, Dr. Deborah Bell. Hello, Dr. Bell. This list of pathology subspecialties partially itemizes the reason why we have a department of 60 members. Our department is divided up into more than 20 subspecialties. All of our specimens are handled by specialists in their areas. As you can see, these areas are demarcated variously, sometimes by the disease condition to which they pertain, sometimes by the organ or tissue site, and in some cases by the special technique for diagnosis employed. Next. Within one of those units, for example, gynecologic pathology, there are 5 pathologists headed by Robert Scully, our senior gynecologic pathologist. Dr. Bell, whose name you will also see there, would you please give us the history on the case you're going to send us an image from, and also commence sending us that image? Hello, Dr. Bell, can you hear me? Can you hear me, Deb?
Good evening, Dr. Blackschaffer. The case that I'm going to send you this evening is a biopsy from a 74-year-old man. He has a darkly pigmented lesion on his foot. I'll begin to send the image now.
Thank you, Dr. Bell. Next slide, please. While the image is being transmitted to us, I'm going to discuss telepathology. The image should be received. Dr. Float will receive the image, be able to start looking at it, and when he's done so and I finished my component of the presentation, he'll discuss its diagnostic qualities and the way in which it can be used to the medical profession. On the end which had sent it. The reason that we're receiving the pathology is because with the teleradiology component of the system, we demonstrated the system as it would be in operation in Saudi Arabia, for example, where the images are acquired and sent to a central international hub. Here we're reversing the process, which is an essential component of the telepathology system. Telepathology diagnoses are needed when consultation is needed. Consultation in pathology, as in all areas of medicine, is needed when the next course of action is not immediately apparent to the treating or diagnosing physician. The best consultant is the nearest consultant if they have the subspecialty qualifications needed to render the diagnosis or advise in treatment. Sometimes there is no appropriate expert nearby. In that case, an outside subspecialist will be sought. Traditionally in pathology, the way to receive outside consultation is by mailing the tissue slides from the specimen received. However, we are presenting to you an alternative to send the images electronically. Next, please. This is a comparison of traditional consultative techniques and the same features of consultation as they are seen in telepathology. The traditional technique, even if sent by an expedited courier, is slow. The minimum time even for the slides to arrive at a consultant is usually measured a day or several days. In telepathology, the time is minutes for the images to arise and hours at most for a consultation to be rendered. In addition, only a single pathologist can be consulted at any given time by the traditional method. You send the slides one place, not many places. The electronic images, once acquired, can be transmitted to as many consultants as are needed to render a definitive diagnosis. Finally, and in some ways most importantly for the medical community in the locale, traditional consultation is not interactive. A diagnosis may come back, but from which slides and which features of those slides the diagnosis was reached is usually not clear. In addition to that, the delay in the diagnosis, in addition to being disadvantageous to the patient, decreases the likelihood of real learning on the part of the local medical team. In contrast, the telepathology consultation is interactive. The images to be transmitted are selected by the local pathologist. When transmitted, they are examined one by one by the consulting pathologist. The consulting pathologist will send back information based upon the particular images. Furthermore, the opportunity, which we would invite you to inspect after our presentations, is there to mark the images electronically and retransmit them back to the original pathologist, constituting not only a medically useful consultation, but also the basis for continued learning and education in each site which has access to telepathology services. Next slide. As you can see, the pathologist who participated in the experiment in 1968 in telepathology at the Mass General is still with us today, Robert Scully, and at the time he examined 100 slides remotely using a black and white television. He got all of the diagnoses right, although he had to ask information over the telephone about what the colors of the slides were in some instances. Next. This is an example of the sort of image which Dr. Scully did not have access to. This is a high-resolution, full-color digital image as acquired without compression. These images, like the corresponding images in radiology, are full of information, which is very useful, but it also makes them very large. Compression, therefore, is essential in telepathology as in teleradiology. Next. As you can see, here is a direct comparison with a highly compressed image. This is at standard magnification. This is the way the image would appear through the microscope eyepiece. Next. To appreciate any differences, and the differences are very subtle and are not sufficient to impact upon the diagnostic qualities of the specimen, one has to actually magnify these images at least twofold, up to fourfold, before any detectable difference in the compressed images can be appreciated. Next. I draw your attention to the first line. That is the image as we acquire it. It, unlike the radiology images, is a mere 1,000 pixels by 1,000 pixels, still the same size as a high-definition television image, but it has twice the complexity in terms of color information at each of those points of light. That corresponds to a 3 megabyte image. As you can see, the various compression modalities reduce that by a factor of 15 to 25 to 1. Next. The corresponding effects in terms of image transmission time, as in teleradiology, are dramatic, reducing the length of time for sending a case from similarly approximately half a day to a few minutes, depending upon the number of standard telephone lines needed and the degree of compression selected. Next. This is a comparison more modern than the 1968 experiment, which also had 100% accuracy, of the diagnostic accuracy of telepathology. As you can see, in the first 3 small studies, it was 100% accurate. The last study, however, is much more interesting because it corresponds to full histologic diagnosis of difficult lesions. There was 98% agreement in the telepathology diagnosis and the diagnosis on glass slides. This level of diagnostic agreement is exactly the same as that between 2 different consulting pathologists, both looking at the glass slides. The conclusion is telepathology does not degrade the diagnostic accuracy. Next. In conclusion of my component, I'll simply summarize. What we're receiving now is a diagnostic image being transmitted in the other direction from Boston, Massachusetts to Riyadh, Saudi Arabia. And this is the reverse, although it would be an educational component of the standard operation of telepathology. In standard operation, the slides would be examined by the primary pathologist. That pathologist would determine, in some instances, that a fully useful clinical diagnosis could not be rendered with confidence by him. In that case, he would seek a consultation. Images would be acquired electronically from those fields which proved to be troublesome or seemed to be significant to that pathologist. They would be recorded electronically, transmitted and stored at the International Hub in Boston, whence they would be examined by a consulting pathologist by the same routing and storage system as indicated for teleradiology. The report would be sent electronically back in a similar manner. The total time for this process, less than 24 hours. Dr. Float, have you seen the image? Yes. Would you care to comment?
Yes, we have received the image from Boston, Massachusetts, and Dr. Bell, by the way, Dr. Float, I'm a dermatopathologist, and this is a skin case where we see a pigmented lesion characterized by nests of cells at varying levels of the epidermis. These nests vary in size and shape. The individual melanocytes show uniform atypia, and the atypia is uniform from the top to the bottom, showing no change in the size of the cells. Therefore, this slide is diagnostic of malignant melanoma. If I could have the next slide. Next slide. This case is diagnostic of the process, so no further process would be necessary. This is not always true, and there are different options for the consulting pathologist, and these include to have more fields transmitted, to have more sections taken, to have special stains performed, or to have the glass slides sent. This pathology frequently in one own institution is an iterative process, and the same iterative process would occur for telepathology. The final result will give a definitive diagnosis equivalent to the standard of care at the Massachusetts General Hospital. In telepathology, as we conceive it, we'll have both primary and secondary consultations in surgical pathology, cytopathology, as well as for special studies. These include electron microscopy, immunoperoxidase, and immunofluorescence. And I hope you have an opportunity to look at some slides. We have examples of all of these special stains available here this evening. Next. The other telepathology applications are similar to those which have been previously discussed in teleradiology. We think that quality assurance is an important issue, quality assurance both for histology, for special stains, as well as for the practice pattern of pathologists. Medical education is an issue for every pathologist, both in the United States and the rest of the world, and we think that this has a unique opportunity for medical education on a case-by-case basis. Finally, I'd like to summarize the telepathology. Advances in telecommunications and computer technology have made telepathology feasible and a highly desirable option for enhancing the diagnostic accuracy for sites without a full complement of pathology subspecialists. Telepathology offers several advantages over traditional glass slide mail consultations. These include the speed of the consultation, as you've seen this evening, interaction with the referring pathologists, and educational opportunities. And finally, a patient anywhere in the world can have access to definitive, rapid, and cost-effective pathologic diagnosis, which can serve as a foundation for optimal local medical care. Pathologists also have a second problem, which we'd also like to demonstrate this evening, and that involves the fact that sometimes one would like to see the gross specimen. And occasionally you'd like to take a picture of the patient to be able to see a more optimal examination of the patient. And Dr. Adrian Gruber will demonstrate some of our gross technology here by taking a digital picture of hopefully His Royal Highness and His Excellency. And he's using a special camera which has a high resolution digital imaging built into it. He will load the image onto the hard drive of the camera, and he will display the digital image here on the monitors here, as well as transmit them back to Boston on a very short period of time. This will take a little bit of time, so in the interim, I think we'll proceed, but shortly you'll see these images come up.
Thank you very much. Well, now that we have seen how we plan to bring telemedicine into life, I would like to introduce Dr. Ricky Richardson, who has been studying the issues of how to practically bring telemedicine and make it accessible to hospitals worldwide, and in particular in Saudi Arabia. Dr. Ricky Richardson.
Your Royal Highness and Your Excellencies, is that a special message from outer space, I ask myself? Colleagues and friends, you've seen today a startling, to me as a clinician, example of how modern technology, especially in the field of communication, can assist those of us in the caring profession, and also, most importantly, our patients. I would like to share with you some operational issues which will illustrate the way in which this system can be brought to benefit patients and physicians and professionals in the health caring profession all over the world. There are three key operational issues on which I wish you to focus. The first is that this system uses ordinary, regular telephone lines. The second is that this is based on a store and forward technique. Unlike a point-to-point video conferencing system, this system is able to handle enormous volumes of data. The third is that being a hub and spoke system, it is expandable. What I mean by that is that as more national hubs develop, more hospitals can be connected to the system and therefore benefit from this extraordinary technology. To give you an example of how simple the system can be, this hall was empty of equipment 48 hours from today. This system you see in front of you, and which you've had demonstrated today, has been installed in less than 48 hours, and as you see this evening, is working. Can I have my first slide, please? You have heard refer to the concept of hub and spoke. This is fundamental to the operation of a system, be it in a country or in a healthcare system within a country. It is based around a national hub or a regional hub which can service information from a number of different hospitals. The purpose of this national hub is to exert quality control and appropriate routing of information. This information, collected and checked, is then transmitted internationally to an international hub, which for our purposes is located in Boston. From the international hub, the data is once more tested and checked, and then routed to the appropriate reading center, on the network. Initially, the readings will be undertaken at the Massachusetts General Hospital and other teaching hospitals within the Harvard system. However, further hospitals and medical institutions will be added until eventually we will have a global network of reading institutions connected to a global network of hospitals, forming a communication bridge by which information can be passed to benefit our patients. Can I have the second slide, please? The national hub is extremely important because it exerts quality control and the ability to route the data to the appropriate location. It's also a focus for introducing new services because telemedicine is a new field and because of that is dynamic and evolving. These evolutions will be extremely exciting and the adaptation of them to the system to the benefit of all its users must be prompt as the applications are identified. The majority of decisions in medicine are driven by images, and therefore there are a myriad of uses to which we could put this technology. The International Hub at the moment is supported, as you see, by Harvard and is located in Boston. I've already discussed the concept of expanding the numbers of reading centers as we develop the system worldwide. Next slide, please. Perhaps I don't want to, I only want to point out one thing in this slide, the fact that the system is user-friendly. We doctors are very conservative. We shy away from new technology, but if it's presented to us in a user-friendly way, we're likely to utilize it. And it is for this reason that I think that this particular system is ideally suited to our needs as a profession. Next slide, please. What about the benefits? The benefits to patients, our primary concern, are that by the ability to seek consultations with colleagues in the global arena, we can identify the appropriate specialist and subspecialist expertise that that particular patient needs. What I like particularly about this system is that the relationship between the attending physician and the patient is uncompromised. It remains, as ever, a special relationship. Simply that the attending physician can reach out to colleagues wherever they may be in the world and seek their particular expertise, which will help that physician make decisions which will improve his or her ability to deliver health care to his patient. Next slide, please. The benefits to the physician are the ability to consult, something we do all the time. Particularly important in my opinion, is the continuing medical educational aspect. Huge resources and archives of medical information will be collected, which can be put into a teaching experience and given back to the subscribing institutions on the network. This will have an enormous impact on the ability of doctors to practice their particular specialty, enhanced by the access to educational material from colleagues in their particular fields. Next slide, please. The thing that I particularly like also about continuing medical education is the opportunities that this will open for collaborative research. This is a very important area to all people in the healthcare profession, and the identification of projects and the sharing of information and research will benefit mankind and our patients wherever they may be. Next slide, please. The benefits to hospitals is basically can be summarized as the more efficient usage of specialist expertise. Specialists are rare, subspecialists even rarer, and the ability to reach out and access such specialists on an as-need basis without having to have them all concentrated in one's own healthcare institution at one time when they're being possibly underutilized from the point of view of their specialist field will be of enormous benefit. Next, please. Lastly, the benefit to national health care systems cannot be underestimated. There are many patients who have to go overseas to seek treatment. There are many patients who have to wait anxiously for a diagnosis to be confirmed and a treatment to be instituted. Reaching out with this service to colleagues all over the world, one will be able to reduce the time and reduce the numbers of patients who will need to seek medical help overseas. In conclusion, I have worked on and off in Saudi Arabia for many years. I've also spent some 11 years working as a clinician in different parts of the world. I think that this particular system is ideally suited to your country, because I think that the ability to reach out to colleagues using this technology is going to be one of the exciting aspects of this decade in medicine, and the people who will benefit ultimately will be the people for whom we are responsible, our patients. Thank you very much.
Well, now that we have received the diagnosis, making a transatlantic medical diagnosis on some CTs, I would like, and I have the honor of introducing Dr. Robert Buchanan. Professor Buchanan is best known today in the United States for standing behind one of the most important moves in medical history in the United States in the last 50 years, the merger between two largest hospitals of the Howard Medical System, the Women's Brigham, and the Massachusetts General Hospital. I propose that Dr. Buchanan is now attempting a next stamp on the medical profession, and that is the introduction of telemedicine into the Harvard Medical System. Dr. Buchanan's commitment to doing that will be illustrated in the speech that we will hear now. Dr. Buchanan.
Thank you very much. First of all, it's my great pleasure to acknowledge with extreme gratitude the patronage of His Excellency, the Minister of Health, for this seminar and for the ability to hold it in this magnificent room. I can assure you that you will find no such facility in Boston. Now, you've seen and heard a good deal about telemedicine. I think you have not heard that we actually started the development of this system in-house in our Department of Radiology under Dr. Jim Thrall, from whom you've already heard. And it really was his vision and the genius of a number of extraordinary young people who created the software and the hardware which have made this show tonight possible. But between the hardware, the software, and the genius, and this show, lies the support and the vision of another group. And I would be remiss if I did not acknowledge the support and the vision and the help we have received from Mr. Yusuf El Zain and his colleagues in bringing this reality to medicine, not only in Boston, but hopefully around the globe. We have at any one time at the MGH 500 young physicians in our clinical programs going through what we call the residency program. In addition, we have a similar number who are in our research laboratories learning to become scientists. Over the years, we've had any number of young people in these programs who came from abroad and who returned to their native lands to assume important leadership roles. But even so, the numbers of young people that we can accommodate especially from abroad, is extraordinarily limited. And we have therefore not had as much impact in the international field as we would have liked to have had. And indeed, as we look forward, because of some governmental policies that are developing in our country, in which I believe are short-sighted, those opportunities for training individuals from abroad may be even more limited in the future than they have been in the past. Accordingly, we view telemedicine as with great enthusiasm as a revolutionary ability to extend the global reach of our clinical education and consulting programs to much larger numbers of physicians and their patients worldwide. At a time of extraordinary advances in medical sciences and technology, this capability promises to be especially valuable, particularly to parts of the world where access to such information was formerly limited or non-existent for both patients and their physicians. We at the MGH are most enthusiastic about the advent of telemedicine as a major technologic advance, which permits us to share the vast resources of our institution and other selected premier hospitals without the excessive costs in time, money, and travel formerly required to gain expert consultations. With the capacity to transmit in real time, two-way, high-resolution images and voice messages at affordable costs, telemedicine offers a new ability to close the communication gaps that for too long have limited access to quality care for too many. The MGH looks forward to working with colleagues and collaborators worldwide to realize the many potentials of telemedicine. Thank you.
Your Highness, Your Excellencies, you can see the image that has been taken by Dr. Gropper, shown to us from Boston. It so happened that the video link has been cut now, but it will be coming back. And this reminds me to emphasize the fact that despite what you see in the imperfection in the video link, this does not reflect itself on the acquired images that have been transmitted. And this is why the colleagues that have looked at the radiological images particularly and at the pathology were able to see them as clearly as we are able to see them on these monitors. Indeed, the ability to see the echo void in the MR images are really tough and are difficult on our current images, and they were seen clearly in Boston. بسم الله الرحمن الرحيم. قبل أن نفتح المجال للأسئلة، اسمحوا لي أن ألخص الفوائد الواضحة للطب الاتصالي، والتي ألخص بها ما جاء في كلمة سعادة الدكتور عبد الرحمن سويل، ألا وهي: أولاً، تمكن هذه التقنية الحديثة من تسخير الخبرات الطبية العالمية لدعم المؤسسات الطبية بالمملكة، وجعل هذه الخبرات متوفرة بصورة متواصلة للرجوع لها عند الحاجة. ثانياً، إيجاد وسيلة مميزة للتمكين من الحوار المستمر ما بين الأطباء فيما بينهم، وكذلك مع زملائهم الاختصاصيين الدوليين، مما يسهل في نقل المعرفة ونتائج الأبحاث. ثالثاً، إن هذه التقنية الحديثة لا شك ستوفر وتخفض الحاجة إلى السفر إلى خارج المملكة للعلاج، أو حتى الانتقال في داخل المملكة من منطقة إلى أخرى، وبذلك يستطيع عدد كبير من المرضى أن يتوصلوا إلى التشخيص والعلاج وهم في أماكنهم، وبذلك يزيد من التطور الطبي في الأماكن النائية. وفي الختام أتوجه بالشكر الجزيل لمعالي الأستاذ فيصل الحجيلان وزير الصحة، وسعادة الدكتور عبد الرحمن السويلم وكيل الوزارة للشؤون التنفيذية لرعايتهم هذه الندوة. كما أتوجه بالشكر لوزارة المالية ووزارة البرق والبريد والهاتف وإدارة الخدمات الطبية للقوات المسلحة، وخصوصا مستشفى الرياض العسكري، لدعمهم الكبير الذي ساهم في إنجاح هذه الندوة. كما نشكر الحضور في القاعة وفي القطاعات الصحية الأخرى الحكومية والخاصة على تشريفهم لنا في هذه الندوة. أود الآن أن أرحب بالأسئلة من الجمهور الكريم.
Well, I must thank you all again for your participation, and I must thank also the group in Boston who have joined us this evening. Assalamu alaikum wa rahmatullah.
It's the future.
عندي خبر لا 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 هذا مو معقول.